With that, I'm going to defer to Maureen Gartner, who is our medical liaison at Parkinson Support and Wellness and the secretary of our board of directors, to introduce our speaker.
Thank you, Chris. Good morning, everybody. We're very fortunate to have Dr. Iris Lynn with us this morning. She is completing her second year of fellowship in a movement disorder program headed by Dr. Espay and Dr. Duker. She did medical school. She did her medical school at the University of Virginia and then her neurology residency at the University of Pittsburgh. She's delightful. She's so smart and she's wonderful to her patients. And you will be learning a lot from her today. So thank you, Dr. Lynn.
Thank you, Maureen. Okay, so hi, I'm Iris, and first order of business is seeing whether or not I can manage to share my screen. Okay, can everybody see this?
Yes.
Okay, great. So I may have met some of you guys already in clinic, but for a lot of you guys, probably not. So I think today they asked me to talk a little bit about the basics of Parkinson's disease. And, you know, I've spent the last 1.5, almost 2 years working with patients with Parkinson's disease. And I think the thing that I've realized is that a lot of what I learn is actually from the patients themselves. People who have had Parkinson's for a while end up kind of being the experts, and they always are full of tips and tricks. And I think support groups like these are so great because you're able to kind of support each other and share your hacks and your tricks. And I think that's really great. But I will start today with just talking a little bit about, you know, getting that diagnosis. What does that mean? What is Parkinson's disease even? Like, what is this thing? And then we'll kind of move into, okay, so now I have this diagnosis. What does that mean for my life? What are some things I can do about it? And I won't get much into research stuff today since you guys do have a talk coming up for that, but we'll just kind of focus on the day-to-day. What is it like to live with Parkinson's disease? So I'll start with, what is Parkinson's disease? So Parkinson's disease, or the entity of Parkinson's disease, is something that has been described ever since like ancient Indian and Chinese cultures. So there are texts even as far back as like 1000 BC describing people, you know, kind of like with tremors or with slowness of movement that sound very much like they're describing basically people who have Parkinson's. But it wasn't formally described in basically medical literature until 1817, and that was by a Dr. James Parkinson, who described it in this paper, and he called it an essay of the shaking palsy. He described a couple of people that he had noticed had this tremor that would occur when they were not doing anything, this resting tremor. A shuffling gait, kind of a stooped posture, and then also problems with sleep, problems with constipation. And then in 1872, then they renamed the condition Parkinson's disease after James Parkinson. So Parkinson's disease is the second most common neurodegenerative disorder, Alzheimer's disease being the first one. So, you know, at least the stats that I have most recently says there's about 60,000 Americans diagnosed with Parkinson's every year. It is a very much age-related disease, meaning that the incidence of it increases as age increases. So for people who are over 60 years old, there's about 1 to 2 out of 100 people with Parkinson's. And then once you hit 80 years old and above, then you get 4 out of every 100 people with a diagnosis of Parkinson's. There's a very small percentage of people who are diagnosed with what we call like an early onset or a young onset Parkinson's. About 4% of people with Parkinson's are diagnosed before the age of 50. And a lot of times in these people, we end up finding like a genetic or a hereditary mutation, whereas the vast majority of people who have Parkinson's, most of the time we, at least so far, don't know of a specific disease or genetic mutation. And we term that as sporadic or idiopathic Parkinson's, which is just fancy way of saying that we don't know exactly what causes it. The estimate is that, you know, by year 2040, there may be as many as 17.5 million people living with Parkinson's, and that's globally. And by and large, the greatest contribution of that is aging, but then there are also other things that may or may not be contributing, which I'll mention in a minute. So what happens in the brain of somebody with Parkinson's disease? So Parkinson's disease is not only in the brain, but it is primarily and mostly in a disease that involves the brain. So there's a part of the brain in the brainstem, and it's called the substantia nigra, which, if you can see in this picture, there's a little area, a little arrow, it says SN, and it's pointing to that little black part of the brain. So nigra meaning, you know, the root word for black. So in that area, you have the neurons that make dopamine, and that's where they're located. And dopamine is that neurotransmitter molecule in the brain. It's responsible for things like learning, pleasure, motivation, coordination, and most importantly, movement, which is what, you know, we notice a lot for Parkinson's. The dopamine neurons do three things. So they store dopamine, they release dopamine when you need it, and they also regulate the levels of dopamine in that junction between the neurons. So it's called the synapse. So in that junction between the two neurons where they're communicating, they communicate with the dopamine, but the neurons also regulate the amount of dopamine. So when you have Parkinson's disease, as you can see in that picture on the left side, it's less black. So that area that used to be very black is less so. So you have loss of those neurons that regulate, store, and release the dopamine in the brain. And that is why it translates into a slowness of movement and a loss of coordination, loss of speed of movement and coordination of movement. When we look under the microscope at brains that have been diagnosed with Parkinson's, you can see these little round, I don't know if you can see on this picture here, I don't know if you can see my mouse, but these little round sort of pink bodies here, and these are called Lewy bodies. And they're basically little balls of misfolded protein called alpha-synuclein. So alpha-synuclein, when it's not squished together in a ball like that, is something that you would normally find in the brain. But then sometimes the protein gets kind of stuck together and squished together. And that's what you end up seeing in, oh, there you go, arrows, in the brains of people with Parkinson's once you look under the microscope. So like I mentioned, Parkinson's does not only affect the brain, it primarily affects the brain. But when people look under the microscope at different parts of the body for people who have Parkinson's, you can also find these Lewy bodies in other parts of the bodies. So you can find it in the GI system, sometimes in the skin, sometimes in the salivary glands. And that is why Parkinson's disease primarily causes brain-related symptoms, but can also cause a lot of things that are very commonly experienced by patients. Not always, but you know, sometimes. I think the big question, and what Dr. Espay will be talking about when he gives his talk, will be what causes Parkinson's disease. And I think the short answer is we don't really know yet. That could be an entire talk of its own. I'm not going to go into it, but I think basically what the predominant thought now is that it's probably not one disease. It's probably a misnomer to call it Parkinson's disease, because it probably is a group of different processes that cause the same sort of changes in the body that end up all looking similar. So it's probably more accurate to call it Parkinson's syndrome, but you know, for the sake of right now, it's before we've clarified those causes, we just call it Parkinson's disease. But in much the same way that you can have a shark and a dolphin and they kind of end up looking exactly the same, but they're really completely different things. It's possible that some of Parkinson's may be more genetically caused, some may be more environmentally caused. There's a lot of research into things that can cause what ends up looking like Parkinson's disease: pesticides, neurotoxins, smoking, heavy metals, head trauma. So, it's a very heterogeneous disease. And I think that is partially why we always say that people with Parkinson's are like snowflakes, where everybody ends up just a little bit different. And there's not a one size fits all kind of picture of Parkinson's disease. So how is Parkinson's diagnosed? It is mostly a clinical diagnosis. And what I say by that is that there is not one specific test that a neurologist can order, and then you get it done, and then they're like, yes, this is definitely 100% Parkinson's, and it can't be anything else. It is still clinically diagnosed because there are tests that can help with the diagnosis. It supports the diagnosis, but the very main meat of what you look at is still clinical evaluation, which means going to the neurology clinic, seeing somebody who is in diagnosing Parkinson's and having them do kind of an examination of your neurological exam. So a couple things that people will have with Parkinson's disease, and the things that we look for that tell us that somebody may or may not have Parkinson's. One is this resting tremor, which is very, very distinctive. So it's this tremor that only occurs when people are, or I should say mostly occurs when people are at rest or not doing anything. So they're sitting there, they're watching TV, they're talking to people, and then sometimes other people will notice it more than they do, and they'll say, oh, that tremor's happening. Sometimes the patient doesn't even notice it themselves. This is pretty different from things like essential tremors, which tend to be more present when somebody's trying to do something. Like if they're trying to use a fork to eat or use a spoon to eat, then that tremor is really annoying and it's always there. Parkinson's is kind of the opposite. Sometimes people who have even that resting tremor, once they go to do something, the tremor goes away. So that's a pretty distinctive kind of tremor. Slowness of movement is also a key symptom. We have a fancy term for it. We call it bradykinesia, but that's why we always have people do these kind of tapping tests and stuff like that in the clinic. When people have Parkinson's, that speed of that movement slows down, and it's even as hard as you try, you can't get it to go faster. And that kind of translates to the whole body as well. So one of the things that families will notice is that somebody's face may become less expressive, their voice may become softer, and their walking may become slower. And it's all sort of this globally slowing down of things. So slowing down of your facial expression, slowing down of everything. The other one that at the beginning stages of Parkinson's is not really as present, but then over a number of years starts to become more obvious, is instability of posture. So that's why we always like to knock you over when you go to clinic, which I know is unpleasant, but we like to check to see if that sort of reflex for catching yourself if you get pulled off balance is still intact. Once you get to a point where maybe that becomes a problem, then it can be something that could put you at risk for falling. And of course, that's something we always want to be aware of and monitor for. And the last one is shown in the video, so I didn't, but it's rigidity, which is basically stiffness. So how loose or how stiff your limbs are. And that's why we'll kind of wiggle your arms and legs around a little bit when you're in clinic, just to kind of feel for that rigidity. And then lastly, there are also a lot of what we call non-motor symptoms. So the motor symptoms are the ones that are related to movement. So the tremor, the rigidity, the bradykinesia, and the instability of posture, but there are also non-motor symptoms. And like I mentioned, because those Lewy bodies can be found in other parts of the body, you can have other things. So it can affect sometimes thinking and memory. Depression is very common in patients with Parkinson's. You can feel weakness or muscle aches or muscle spasms. A lot of people have restless leg syndrome. There can be problems with swallowing or trouble with drooling. A lot of these things are sort of like like a grab bag. Like some patients will have it and some patients will not. And a lot of these also become problems as the disease progresses. So usually aren't problems in the first couple of years that somebody has Parkinson's, and then maybe after many years of having it, they become things that people will notice. So that's just something to be aware of. I think I always tell people, like, don't read about all the possible symptoms of Parkinson's and then freak out and think you're going to develop every single one, because that's not true. Everybody is different, but it is something to keep in mind, because sometimes, maybe you and your PCP are trying to figure out why it is that you drool so much and you're trying to do all these tests and stuff, but it's just Parkinson's. So it's something to, if you have something new, it's always good to check with your neurologist and say, hey, do you think this could be the Parkinson's, or do you think I should, continue looking for other reasons for these symptoms? So I just want to pause and explain the term of Parkinson's disease versus Parkinsonism, because this can be very, very confusing. And in fact, I was confused by it when I was starting medical school. So it's definitely a confusing thing. So we have this entity called Parkinson's disease, which I've already discussed is more like Parkinson's syndrome than anything else. But Parkinson's disease is within that umbrella term of what we call Parkinsonism. And Parkinsonism is simply any kind of disorder that causes that combination of the slowness, the stiffness, and the resting tremor. So Parkinson's disease is by far the most common cause of Parkinsonism in the general population. However, there are many other causes of Parkinsonism, and usually we would call these like an atypical Parkinsonism, whereas like a classical kind of Parkinsonism would just be like a Parkinson's disease. So there are a couple of other entities which are also neurodegenerative, meaning that they are caused by the loss of neurons. And these are very similar to Parkinson's disease, but with some slightly different characteristics. So for example, with dementia with Lewy bodies, it's very similar to Parkinson's disease, but typically people will have more cognitive problems, more memory problems, less of the slowness, stiffness, and tremor problems. People with multiple system atrophy may have a lot more problems with blood pressure, like way more problems with blood pressure than Parkinson's disease. So they're just slightly different flavors. And so sometimes if people say like you have Parkinsonism, but you don't have Parkinson's disease, that's kind of what they're talking about. And it can be confusing. There are also other similar like genetic or infection or autoimmune conditions. Some drugs may cause symptoms that make people also have Parkinsonism, meaning slowness, stiffness, tremor, but may not be because of Parkinson's disease itself. So this is when, just clarifying things with your neurologist is helpful. And I will say that a lot of times, some of these conditions at the beginning look very similar. And because there's not one test that we can do, sometimes it takes a little bit of time in working with your neurologist over time for them to monitor your symptoms, monitor your progression, for them to be able to arrive at saying, okay, this is what your actual diagnosis is. So moving into what can we do about Parkinson's? So now you've been diagnosed with it, and that's a huge diagnosis. It's a life-changing diagnosis. And so we'll just talk about a couple of different areas of things that could be done. So I think the main buckets that I'll cover today is exercise or therapy, diet, medications, and then what we call advanced therapies, which is kind of like beyond medications. So we'll start with exercise and therapy. So far, there's a lot of different trials going on in research for Parkinson's. And I think the holy grail has been looking for something that is disease modifying. And that just means looking for some kind of drug or intervention or something that can slow down the progression of Parkinson's or even reverse the effects of Parkinson's disease. so far, the only thing that we have really shown to slow down the progression of Parkinson's and possibly delay the onset of Parkinson's is doing exercise and physical activity. So, I think that this is something that is beneficial on many different fronts, not just in preventing neurodegeneration, but also cardiovascular benefits, many other health benefits. People sometimes will ask, like, what kind of exercise should I do? Should I just do boxing? Because I feel like boxing is the most well-known, like, Parkinson's exercise. And we always say that the exercise that's the best is the one that you're going to stick with and then keep doing. So find something that you are interested in enough to where you will stick with it and keep doing it. It's good to try to exercise at least to the intensity where you're a little bit short of breath, like where you're exercising, you can't like hold a full conversation. You have to catch your breath. That's when you know that you're actually doing enough strenuous exercise to kind of get those benefits. I will say, of course, if you have other conditions, if you have heart conditions, if you have lung conditions, definitely check with your doctor before you start exercising really strenuously. Make sure that your body can tolerate that before you do it. I know there's a lot of different exercise and activity groups that are available in the Cincinnati / Ohio area. I'm sure that's something that you guys can just log on to and find. There's a lot of different things available for you guys. So next, let's talk about diet. So a lot of people ask about diet, and I think that, like that diagnosis time period is a really good sort of, I've heard it referred to a lot as being a wake up call. It's an opportunity to take stock of your lifestyle and pause and say, what could I be doing better? What are some healthier habits that I could be incorporating? And I think diet is one place where there's a lot of potential for improving lifestyle, because as we know, a lot of the things that we consume in America, and they may not be the best for our health. The diet that is the most recommended for neurodegeneration standpoint is what they call the MIND diet. It's basically, it stands for Mediterranean - Intervention for Neurodegenerative Delayed Diet. Anyways, it's basically a combination, a hybrid of the Mediterranean and the DASH diet. You can find it online if you look. Okay. And it is a focus on more whole grains, leafy greens, other vegetables, berries, beans, nuts, lean meats, and also trying to cut out things like processed foods, fried foods, butter, sweets. So that's something to really focus on. There is a lot of, there's good evidence that following the MIND diet prior to the development of Parkinson's may delay the onset of Parkinson's, which I know is a little bit like not as useful if you've already been diagnosed. But there's also some evidence that incorporating the MIND diet improves cognition in patients who have already been diagnosed with Parkinson's. So I think as much as possible, trying to adhere to that kind of diet is a good idea. In terms of vitamins and supplements, so a lot of people ask about these. There's a lot of information out there about various trials. I think thiamine is one that I hear a lot about. The one that is pretty solidly researched is the fact that vitamin B12 and folate, which is vitamin B9, tend to be low in patients with Parkinson's, especially those who are on medication. And the reason is because the medication for Parkinson's, which is the levodopa or Sinemet, can sometimes interfere with the processing of these vitamins. And so after a while, after a period of time of being on levodopa, a lot of patients end up being deficient in vitamin B12 and folate, and sometimes vitamin B6. Vitamin B6, there's an exclamation mark next to, because B6 you can get too much of. B12 and folate, you kind of can't get too much of it. So if you want to take vitamins in addition to dietary sources, that's fine. Vitamin B6, unless you're doing like a B complex vitamin, those are safe levels to take, but don't go out and buy like a giant bottle of B6 and start pounding that, because you can get too much of that and that can opposite cause neurologic problems. So I would say taking a B complex vitamin is probably a good idea, especially if you're taking Cinmet or levodopa on a regular basis. All right, so medications. So I'll kind of just start by saying, like, you've just been diagnosed, should you even take medication? Medications that we have right now for Parkinson's are symptomatic, meaning that they're not that holy grail of medication that can slow down the disease. They are purely things that will treat your symptoms and make you feel better. However, there is research that shows that people who delay starting medication may not do as well in the long run. And we don't think that's because the medication slows or stops the Parkinson's. It's probably because the medication allows people to move better, to walk better, to exercise better, to keep working if they're working, to maintain their relationships, maintain their social activities. And that's incredibly important. And so some people will say, you know, I have this tremor and it's not bothering me and I don't want to do any medication for it. And that's totally fine. If it's not interfering with your life, if it's not bothering you, if you're not limiting anything you're doing, then that is totally fine. But I would say that if you find that it's interfering with your ability to do your work, that you're not doing things you would like to be doing because of your Parkinson's symptoms, or if you're having falls, then that is reason to consider starting medications. The mainstay of the medication is carbidopa-levodopa, which is also called Cinmet. It is basically replacement dopamine. So as we discussed, the dopamine neurons are lost during the Parkinson's disease process. And so we're just giving you back the dopamine that you would have made yourself otherwise. This has been around for a very long time. It's a very old drug. It is the best tolerated in terms of side effects for all the Parkinson's medications, and it's the most effective. It comes in a couple of different formulations. Most people, when they start out, will be on this yellow one, which is the 25-100 formulation, but it does come in other ones. It comes in a slightly more extended release one, the CR, which some people will take at bedtime. The most common side effects include, well, actually, I'll talk about that in a minute. So this is a patient who is before and then after taking dopamine. As you can see, significant amount of difference in terms of the speed of movement and the ability to walk better. So when somebody is first diagnosed with Parkinson's, typically in an early stage, you take that levodopa and it improves your symptoms. We start calling it kind of on versus off periods. And then off period is being that time when somebody is very slow, very stiff, has a lot of tremors. And then on periods being that once you've taken the levodopa, you have improvement in that and you're able to move faster, better balance, better stiffness, so that you're looser and less tremor. So when you first get diagnosed within the first couple of years, it's very easy to just get you out of the off periods and get you on. And then you have to just keep in mind to take the levodopa on a regular dosing schedule. Your brain has a constant dopamine release, and we're trying to emulate that as much as possible. So you want to be taking it on a regular schedule instead of just like all over the place randomly, because then your brain gets really confused. If possible, it's good to avoid taking it together with proteins, because proteins do interfere with the absorption of the Cinmet. However, keep in mind, like I said, the whole goal of this is to get you to be able to do your regular activities without interference from your Parkinson's. So that does mean that if taking it away from mealtime is just too much for you, the timing, the schedule is too much, or you can't remember to take your medicines unless you take them with your meals, that's fine. Just let your neurologist know you're doing that so that your dosage can be adjusted, because you may need a slightly higher dose if you're not absorbing it very well because you're taking it with food. If you're able to, try to avoid taking it with food for the best oomph that you're going to get out of that one dose. And then sometimes if you take it with food and you're like, oh, that dose didn't work as well, just know that that's why. It's because the food probably interfered with it a little, but your next dose should work just as well again. The most common side effects include nausea, something called orthostatic hypotension, which basically means that your blood pressure doesn't compensate as well when you stand up. And so it can drop down lower, and people can get lightheaded or dizzy. And then uncommonly, it can also contribute to hallucinations. Typically, that's only a problem in people who kind of already have hallucinations, but it can make hallucinations worse. So these are all things that you should tell your neurologist if you notice having these side effects, because there are treatments for each of them. We can do things about that so that you can continue to get the benefit from the levodopa without having to suffer the side effects from it. There's a whole host of other medications that are helper medications with the levodopa. All of these are used kind of in different ways. The first two categories, which are called the COMT inhibitors and the MAO-B inhibitors, you can kind of think of them as fuel additives. They kind of work to help keep the Sinemet, the carbidopa levodopa, in the system for a longer period of time before your body processes it out. So it keeps it in your system for longer. The dopamine agonists are very similar to the levodopa, carbidopa, levodopa action, but they're a little bit different and come with a little bit more side effects. Actually, all of these, I would say, just any of these kind of additional medications tend to have more side effects than just straight up carbidopa, levodopa. And that's why most of the time we don't necessarily start with these medications. These medications come into play a little bit later on when maybe the carbidopa, levodopa by itself isn't doing enough of a job there. And then the last medication is called amantadine, which there's now a branded extended release version called Gocovri. And this medication is helpful for dyskinesias or extra movements. So let's talk a little bit about that. So like I mentioned, when you first kind of get diagnosed, it's very easy for us to hit that therapeutic level where you're in a good on state, you're feeling good, your tremor's gone away, and you're able to do all the things you want to do. As the years progress, and this is a very slow progression, it's typically not a quick thing, but as the years go on, people can start getting a little bit more unpredictable on and off sort of response. So sometimes maybe you take a dose and you don't get that kicking in that you're used to, which we would call like a dose failure. And then sometimes you might notice that your doses are wearing off sooner than they used to, and you're kind of left with that tremor for about half an hour or an hour before you're due for your next dose. And then sometimes people may notice extra movements. So that's illustrated in this chart by these little peaks at the top of that blue area here, where you kind of get into the area where you're having those extra movements. And those are what we call dyskinesias. So I think people are more worried about dyskinesias than anything else that I talk to when I first talk to people with early Parkinson's. So I just kind of want to explain it a little. In the past, and I think unfortunately common knowledge for some doctors still, is that dyskinesias are caused by taking dopaminergic medications. So some people will say, don't take your Sinemet now, you just got diagnosed, save it for later, because if you take it now, you're going to get dyskinesias in a couple of years, and that'll be because you took the medication. So that is something that is really an outdated knowledge. There's been a lot of research that disproves that. Now we know that the dyskinesias are related purely to just the progression of Parkinson's disease. So let me kind of explain that. So in the early years, when people have Parkinson's, you've lost some of those dopamine neurons, but you still have some left. And so those dopamine neurons that are still left, they're still able to do the job, taking up the replacement dopamine that you've given them, the carbidopa, levodopa that you took, and then they keep them, they, remember, they store the dopamine, and then they release it when needed. And so you're almost pretty much able to compensate for the loss of the neurons that you already have gotten rid of just by taking your levodopa regularly. And that's kind of when people are really even throughout the day and they don't notice any fluctuation. But over the years, as you have less and less of those dopamine neurons left, then the remaining neurons are less able to compensate for it. So you get kind of unreliable responses. The neurons that are left, they can't store as much dopamine and then release it the way they used to. And additionally, your brain tries to help by it tries to pull some neurons that were not meant to do this job to help do this job, because now they don't have any neurons left that originally did the job. So it starts pulling in these non-dopamine neurons to help do this job, which they could kind of do, but not very well. So they sorry. Okay. But so it's kind of like they kind of sputter a little bit. And so the combination of the fact that you only have a little bit of those neurons left that can release the dopamine, regulate the dopamine, store the dopamine, and then you also have neurons that are pulled in to do this job that are not meant to do this job, means that sometimes you get those excessive areas of excessive stimulation, and then you also get times when maybe that stimulation doesn't kick in the way you want to. But this is related to the duration of disease, meaning how long the Parkinson's process has been going on. It's not because of taking the medication. So, they've done trials looking at, for example, if you take somebody who has had Parkinson's disease for 10 years, they've been treated perfectly well, and at the end of 10 years, they get some dyskinesias. And then you take somebody else who has had Parkinson's disease for 10 years, but they never got it diagnosed and they never took medication for it, and they only found out about it now. And then you start them on medication for it. Both of them will have the same likelihood of developing dyskinesias at that point. And that's just because they've had the same duration of disease at that point in time. Okay. So a couple of questions that people often ask: will reserving the medications now prevent me from getting dyskinesias in the future? No, it doesn't change the potential for dyskinesias. And it may cause you to be off more. It causes you to be slower, stiffer, restrict your physical movement, restrict your social activity, and we don't want that. And then what can be done about dyskinesias once they occur? So a lot of times when they're mild, people just ignore them, because if it's just like my foot's kind of wiggly, but it doesn't really bother me, it's not necessarily something that has to be treated unless it's really bothering you. But once it bothers somebody, there are a couple of tricks up our sleeve. We can lower the dose of the Cinemet. We can add on something to treat the dyskinesia, something like amantadine or Gocovri, or we can consider what we call advanced therapies. So there are things that we can do to treat the dyskinesias. The goal is to try to get people to a good therapy just to be on without the dyskinesias being bothersome. We may not be able to eliminate them all the time, but at least to get them to where they're not as bothersome as they could be. So there are a whole host of other medications for all the different other symptoms of Parkinson's. I'm not going to go into these in detail just because each of these topics could be their own talk. But suffice it to say, there are treatments for each of these other symptoms, constipation or trouble with thinking or memory or hallucinations or excessive drooling. One of the ones that people run into the most, and something that just keep in your mind, is drops of blood pressure with standing. That is something that Parkinson's disease can cause, and the medication for Parkinson's disease can also worsen. So if you start noticing that you get really lightheaded or dizzy every time you stand up, then that is something to mention to your neurologist, because there are things we can do about that, and medications that can help for that. So in terms of medications, there's a lot of different tricks that we can pull out of our bag to address the different symptoms that you have. So, talk to your neurologist, and we can always try to troubleshoot things. So let's talk about advanced therapies, which when somebody's just diagnosed is usually not as applicable, but just to let you know kind of what's out there. So one of the things that people have developed is called a carbidopa levodopa intestinal gel. Goes by the brand name of Duopa. So as you remember on that graph, when you take a dose of the Cinemet or the carbidopa levodopa, that dose goes in and then the level goes up and then it comes down. And that's why you have to take it multiple times in a day. This is a way to deliver the carbidopa levodopa in a consistent fashion. And we're trying to basically mimic what your brain would be doing if it was still producing the dopamine on itself. In this technology, there's basically a small feeding tube that's placed into a stomach, and there's a little port that's placed surgically in the stomach wall, and that is connected to a pump which delivers the intestinal gel into the stomach directly, and then down into the small intestine via a small tube. And this is nice because it bypasses the stomach, and so you don't have that interference with absorption as much. And then also allows us to give a constant rate instead of taking each dose and having it go up and down. Of course, it can also kind of be, cumbersome. You do have to have a feeding tube with like a tube coming out, and then the pump has to be worn on the body. I would say that I don't have as many patients with this. I think it's a good technology, but it may soon get replaced. So I think we're not doing as many new patients for this nowadays. What we are doing a lot of is deep brain stimulation. And that is a procedure. It is a brain surgery, but I think in terms of brain surgeries, it's one of the safer brain surgeries. It's a procedure where they will make two small holes in the skull, and then electrodes are placed down into the brain to stimulate the parts of the brain that control the movement. And by stimulating this, we are able to basically mimic the effects of the carbidopa levodopa. So I think a good way to think of the benefits of it is it basically does the same thing as the carbidopa levodopa does, but at a constant rate and without that fluctuation. This is something that we really start thinking about in patients who have had Parkinson's for at least 4 years and have started to notice that their doses are wearing off really fast, that they're having trouble with a lot of dyskinesias, and it's hard for us to manage it just with medications. Or for those patients who have a really bad tremor that we can't seem to get control of without running up against a lot of side effects from the medications to control tremor. It's not a great idea with people who already have a lot of memory problems or a lot of hallucinations, and also not a great idea for people who have a lot of depression or anxiety that's not controlled. So it doesn't mean that that's an absolute contraindication. It just means that we may advise talking to a therapist or seeing a psychiatrist or doing something to optimize somebody's mental health to make sure you're in a really good point to be able to go forward with something like, brain surgery. So, this is something that your neurologist may bring up if it becomes a little bit difficult to control the symptoms with just medications alone. So things coming down the line, there's this system, there's actually, I think, 3 systems coming down the line for subcutaneous infusions. And this is what I mentioned, I think may end up sort of replacing the intestinal gel version, but it's similar to where you would wear a small pump, but instead of placing a feeding tube, it would just be like a patch with a needle that you would stick on the skin of the belly, and the small needle would then deliver the carbidopa levodopa underneath the skin where it would be absorbed. It's very similar to some systems for diabetes these days where they deliver the insulin straight underneath the skin. So that is in the, there's a couple systems that are in the, like phase 3 trial periods, and one of them is pending FDA approval. So I think we will hopefully get these within the next year or two. And I think the people who have gotten them so far have liked them, at least that's what Dr. Espay is telling me. He does run one of the trials at UC. So I'm excited for these coming down the line, and I think these will be kind of a game changer. Another thing that some people might have seen is focused ultrasound. Focused ultrasound is something that's mostly used for tremor treatment these days, not Parkinson's, but just essential tremor treatment. There is some research on doing it in Parkinson's patients. It's not something that we're really doing routinely as of yet, but it's something that's being researched to see if basically it could be similar to the deep brain stimulation and offer similar benefits, but without doing the cutting into the brain part. Now, it's a little bit different in that once you do it, you can't adjust it. The deep brain stimulation offers that benefit where you can adjust the stimulation, you can turn it up, turn it down, change the direction of it. With focused ultrasound, you wouldn't be able to do that. It would just be like one little, like it would burn a little hole, and then that would be it. So it's not as customizable, but it is something that people are looking into to see what role it could have in Parkinson's. Oh yeah, that's just a video of what happens. And then lastly, there's a whole lot of research on genetics and genetic therapies, all of these different genes that have been identified that are associated with Parkinson's disease. Like I mentioned, most of the patients that have an identified genetic mutation at present tend to be the people who have a younger onset of Parkinson's, or people who have a lot of family members who all have Parkinson's. So, most patients will not have an identifiable mutation, but it is something that we're able to test for, at least the most common mutations at present. So if that's something that you're ever interested in, just talk to your neurologist about. That's something that we can test for if you're curious about it. But the hope is that someday we'll have more specific genetic therapies that will target specific mutations and correct those mutations at the molecular level, maybe even to prevent somebody from even developing Parkinson's in the first place. I wanted to mention the University of Cincinnati, the kind of major push towards this direction. It's called the Cincinnati Cohort Biomarker Program, headed by Dr. Alberto Espay. And he's basically trying to look at all these people with different neurodegenerative disorders and trying to see, what is special about each person. Because I think we've realized that treating Parkinson's as one big chunk, Parkinson's disease, is not going to work, because it's not one simple disease that there's one thing that causes it. It's a whole grab bag of different things that could be contributing. So that means that our treatments are going to have to be tailored to, each person's different disease, as opposed to being like this one drug will cure everybody with Parkinson's, because I don't think that's going to be something that will ever pan out. Okay, so that takes me basically to the end of my presentation. I think I would just say, let the diagnosis kind of be a catalyst for you to take a look at your life and figure out different things that can be done differently, and always talk to your neurologist about different problems that are coming up. And I will say the one thing is write stuff down. I literally made a note for myself yesterday on my calendar, and I woke up this morning, I have no idea what that note is about. I can't remember anything. So I don't expect you guys to remember things either. If you have a question, make a note of it. If something happens that you want to talk to your neurologist about, write it down, so that when you see us in clinic, keep in mind we only have so much time together, but I want to maximize that as much as possible and answer as many questions that you have as possible. So just write it down, so that once you get there, you'll have all of them and we can go through them and talk about them. So that's all I have.
So I have a question. Iris, can you talk a little bit more about dyskinesia? In terms of, Dr. Espay always says, if you have dyskinesia, that's really good. And then everybody's wiggling and, losing weight and everything else. But explain that slide again about how it happens.
Yeah, so I think that the reason that it's complicated is because it is not 100% clear why it happens or how it happens. There are theories though, and this is, one of the ones that at least to me like makes a lot of sense. I think that it is a very valid way of thinking about dyskinesias in the way that Dr. Espay does. He describes it as the price of success. And I think that is often true because most of the time, the vast majority of time, dyskinesias are related to the too much dopamine stimulation. And so if you just make it very simple and you think about Parkinson's equals less movement, and then dopamine gives you back that movement. And sometimes we give you back too much, and then you're moving too much, and that's dyskinesias. But, I think that most of the people, if you are on, meaning that you have good treatment of your stiffness, slowness, and tremor, then that is the time that you will get dyskinesias. And so, I think that it is true that it is what we call price of success, because once you get to a high enough level to where you're adequately treating the Parkinson's, you might get some dyskinesias. But I think that dyskinesias, once they get to be fairly significant, they can be quite bothersome. And yeah, I've seen research about how, and nobody's sure about this, but there are theories that maybe dyskinesias contribute to weight loss, because just a person who is wiggling around all the time versus a person who is still is using more energy, and maybe that is contributing to weight loss, which we don't really like in Parkinson's. We like people to keep up their weight and not lose a bunch of weight, because that makes you more fragile. So I think that it is a good idea to try to address dyskinesias as much as possible. But, I think it is kind of a little bit customized to the patient, because some patients say, I would rather be dyskinetic than to be off, because being off is so uncomfortable for me. But I think that as far as the physiology goes, in terms of like this very simple depiction that I sort of created out of nowhere, but I think one thing that is good to think about is those like extra neurons that come into play, like the ones that were not meant to handle dopamine. Your brain has a really, really good capacity for compensating. So if you've ever heard of, for example, like some people who have like a stroke where they lose their use of their right arm, and then they've done studies when they try to tie the right arm down, and then your brain will eventually start using the part that controls the left arm to come control the right arm. So your brain can compensate, and it can kind of try to accommodate injuries that it has. And so I think that one way that happens is your brain starts pulling in these neurons that were not meant to do stuff with dopamine, but they're able to a little bit, but they're kind of bad at their job, but they do their best. And so then you get these like unreliable sort of like ups and downs. And then when you combine that with the fact that carbidopa, levodopa is absorbed in the stomach, and then you have to go through, so like your levodopa has to go through you swallowing it, getting into your stomach, making sure your stomach is digesting it, which is not a sure thing, because a lot of times people have constipation, their stomach is not digesting things as well, it's not moving things along as well. And so you have to digest it, it has to get into your bloodstream, get up to your brain, and then your neurons use it. So it's a long journey for the levodopa to go on, and that's why kind of managing this gets complicated. If we were able to just target specifically the level that you need it in the brain all the time, then I think it would be very easy for us to avoid things like causing dyskinesias with the levels of medication. But I think that's what makes it difficult is the level of variation in everybody when you're titrating these doses.
And the other thing too, I always talk to patients about is we don't know how many dopamine receptors, there's no way to measure that. So we're always kind of a shot in the dark with treatment, taking our best aim.
Yeah, that's true. And I think that's why, once you'll get to know your neurologist pretty well. A lot of back and forth and adjustment up and down in terms of trying to figure out what dose works well for you, and what dose may be a little bit too much. And sometimes the difference can be like a fourth of a tablet, as small as that. Some people are just that sensitive. And so there's a huge amount of variation and troubleshooting that we're able to do in terms of trying to balance that out.
Thank you.
That was so cute.
Do you see that question about the DNA?
I see effect of Parkinson's on singing. So I think in terms of singing, Parkinson's definitely can affect the voice. And most of the time, people end up speaking more quietly, and that can make it, I could think that could affect singing as well. It's actually not, it's a combination of things. It's a combination of the Parkinson's making the voice softer, but also Parkinson's seems to affect the way that people perceive their voice. So it's almost like people with Parkinson's think that they are talking at a normal level, but it, like, in their head, it feels like a normal level, whereas to everybody else, it's a softer level. So that's why things like speech therapy can be helpful, because they teach patients with Parkinson's how to try to add an extra level when they're speaking, so that to them, they feel like they're shouting. But then to everybody else, it feels like a more normal level, and it helps with communication. So let's see this question.
What I've discovered is that my voice is louder now than it was before PD. And that's the observation of other people around me. I'm a trained singer.
I see.
So my model for this is that some of the bad habits that I learned when I was a self-taught singer years and years, decades ago, are not as held strongly as they were before Parkinson's. So I've unlearned some bad habits vocally.
That's cool. Yeah, like I said, I learn so much from patients, because I can't count the number of times when somebody will say, this thing that's supposed to happen, the exact opposite thing happens with me. And I'm like, I believe you, but I don't know why. Everybody with Parkinson's is a little bit different. I see a question here about DNA testing. How come the doctors aren't automatically doing DNA testing? I've never heard it brought up. How does one get referred to the biomarker clinic? Will UC test out children if my Parkinson's is DNA? So one thing is I'm just going to drop the link for the biomarkers, the biomarker study that's being run out of UC. So you can just go online and look at that website, and it will take you to the information for that biomarker study. It's like a once a year visit, and they do some imaging and blood work, but it's nothing invasive, and they're not giving you any medication or any kind of new thing or anything. In terms of the DNA testing, I think the short answer is that because it doesn't change how we treat people with Parkinson's right now. So most of the time, the genetics of it is informative if there's something we can do about it that's different. For example, for cancer, they always test some of those genetics because it influences what medication they're going to choose, how effective certain treatments are going to be. For Parkinson's, most of the time, even if we know that there's a genetic mutation, it doesn't affect how we treat the Parkinson's. We're still going to use the same medications. We're still going to use the same strategies. And so there's not a routine testing for it, because it's going to be expensive without really giving you any additional benefit to managing your Parkinson's disease. It is helpful if people have a strong desire to see if there is a chance that their offspring, if their kids, could be affected by it. It is mostly done by a company called Invitae. And a lot of times I've had pretty good luck with getting insurance to pay for it. So it's pretty easy for us to send a blood sample. It is just a blood draw, and then they send it off to Invitae, and then they can test for a panel of the most common genetic mutations found in Parkinson's or found to cause Parkinson's. I will say that, like I mentioned, the number of people with identifiable genetic mutations right now is pretty low, like somewhere around 4 to 5% of patients maybe. The vast majority of patients, there's no identified genetics. That doesn't mean there isn't a genetic mutation. It just means that we may not know about what exactly it is yet, so we can't test for it. And so most of the time it's not worth it to test everybody with it, because most people will just come up negative. But if you're interested, I would say, yeah, just talk to your neurologist and ask them if they can order a panel testing for the genetic causes of Parkinson's, because it's pretty simple to do, and it's just a blood test. Typically, I think the cost of it will be somewhere around maximum $250 if it's self-pay, but sometimes insurance will cover it, so they can check to see if insurance covers it.
Okay.
I
Chris,
just,
you want to wrap it up, or
we
Yeah.
can't hear him.
Chris, you're on mute.
Oh, I think he knows he's on mute though.
No, he didn't.
Oh,
Sorry, Mary Jo, I was talking to you to
Oh,
please go ahead.
I just had a couple things. I'm so proud of myself when I learned how to do something new. And a screenshot I did a couple times during this. Do y'all know what that is? You hit the window key, and the PRTSC is at the top with mine. Anyway, it can help, because taking notes is difficult. And along that line is, do people with Parkinson's tend to have more problems texting? Because I don't know, it's like, even I'm trying to have a stylus near me, The other thing, just quick, why is it that the drugs don't help during the night? I mean, obviously you're not getting up except to go to the bathroom, but I've had more people ask me why you don't take something at night normally. That's it.
yeah. So first of all, in terms of texting, yeah, that can definitely be a challenge for a lot of people. I think tremor can make it hard. And then also dexterity, the slowness can affect your ability to coordinate movement in the hands. That can make it hard. I know at least University of Cincinnati, we have a great occupational therapist named Jen Torbeck, and she works with what we call assistive devices, which is basically like slightly different keyboards or slightly different styluses that make it easier for people to continue to try to use their devices, maybe with a special adaptation. So that's something that we can try to help with if she has, to see if she has some ideas for things that would make it easier. In terms of overnight treatment, so a lot of people at the beginning, especially the beginning couple years, will have something called sleep benefit, which means that they find that actually in the morning when they wake up, they feel pretty good, and overnight they don't feel like they're particularly off or anything. And I think it's just because overnight you're not doing as much, you're moving around less, and so you're not needing as much dopamine in your system. So remember, you're at the beginning of the disease, you've lost some neurons, but you haven't lost all of them. You still have some left. And so initially, at least overnight, those neurons that are left, they're sufficient to give you the amount of dopamine that you need to just sleep and then go to the bathroom and then go back to bed. The longer that the disease progresses, typically most people will start noticing overnight, I have tremors, overnight I'm really stiff, it's hard for me to get out of bed to go to the bathroom, that kind of stuff. And that's when we start adding on medication overnight. the challenge comes in that you can't give somebody a medication every 4 hours overnight, every 3 hours overnight, because then you're just waking them up all the time, right? So then we have to try to rely on slightly more extended release formulations overnight, so that we're allowing you to get plenty of sleep while also treating you for those times when you might get up. So it gets a little bit challenging, but that's why, you know, maybe a couple years on, somebody, your neurologist might suggest adding on an extended release version, especially at bedtime, right as your head hits the pillow, so that it works overnight, and then you're not going to have too much trouble getting up to go to the bathroom and things like that.
Thank you.
Yeah.
Thank you, Dr. Lynn, and thanks everyone for your questions and your attention. We appreciate both the presentation and the answers to these questions that we don't often get a chance to ask or don't remember to ask when we see the doctor or our nurse practitioner. That will conclude Dr. Lynn's portion. It is now 12:15. I think instead of taking a bio break, I'd like to ask our panel to go ahead and get started. And if you need to take a bio break, feel free. We promise not to peak, or you can turn off your video if you so desire. And just before we start with our panel, there was one question that was asked that was probably asked more for me than for anyone else, and that was, since we are recording this session, where will we be able to find the recording? And so I'm sharing my screen right now to show you that our website is Parkinson, no S after Parkinson, parkinsoncincinnati.org. And if you go to the Learning tab, you will see that we have two primary areas of learning, Springform and PD EDU. This is a PD EDU. And if you scroll down on the PD EDUs, you can see our previous sessions, PD EDU sessions, so you can find a topic that you may be interested in and jump in right there. It usually will take us about a week to edit the recording and get it up on the website. So look for it next weekend or early the following week. With that, I'm going to introduce Elizabeth Grover, who is a person with Parkinson's who is very active in the Parkinson's community. And in particular, we are fortunate that she serves in multiple roles with Parkinson's Support and Wellness, including as the vice chair of our board of directors. And she'll be leading the panel that includes a couple other of our friends with Parkinson's. Elizabeth, if you'll go ahead, and Dan and Rick, if you'll unmute your mics, please.
Thank you, Chris. Many of you are probably newly diagnosed, and that's why you're at this basics program, and you need more information. And you've gotten lots of information from Dr. Lynn and from your own doctor. But what they haven't told you is what it's like to live with Parkinson's, because they can't tell you that because they don't have Parkinson's. That's why we've added this component to the program to give you some information from the perspective of 3 patients who live with it every day. Dan Burton is going to be speaking to you, and Rick Isles as well as myself, and we're going to answer 3 sets of questions. One is, what was our reaction when we were diagnosed? What were our fears and expectations? The next one will be, what has the reality been? How have our fears and expectations been realized or not realized? How did our symptoms progress? And the third question will be, what steps have we taken to manage our Parkinson's disease? So the first question, what was our reaction when we were diagnosed? And what were our fears and expectations? So Dan, can you give us a quick introduction of yourself and answer that question for us, please?
Sure. Good morning. Good afternoon. I was diagnosed 11 years ago, and
It says right there.
It was a rather abrupt introduction. I had some pill rolling features that my wife, as a nurse, recognized and said, well, you're going to need to get an appointment with our PCP. And so I got the appointment, and he sent me off to a neurologist who was not does not have a good bedside manner. He his assistant was not there, who usually dealt with the patients, and so he just did the test that you all had to do different tests. And he said, "What do you think?" And I said, "I think something's wrong." He said, "Yes, something's wrong. You have Parkinson's disease." And I said, "What's that mean?" He said, "Well, my assistant usually tells you about that, but basically, you have 4 stages." He said, "You're young. You're 48, so you probably will go through these stages 2.5 years at a time." He said, "Your tremor on one side will go to both sides, and then you'll not be able to walk, so you'll be in a wheelchair, and then you won't be able to swallow, and that will be the end." I said, "You mean I've got 10 years left?" He said, "Yeah, 10, 11. I said, "You gotta be kidding me." He said, "No." And I had boys that were 18, 16, and 12, and my wife of 23 years was in California helping her stepmother at the time. So it was a shock for me, and I didn't know what to do. So my wife and I spoke that night, and she's a tremendous strength for me. But my fears were that my thoughts were dyskinesia right away, that I wouldn't be able to go out in public, and that I was only going to be around for 10 more years. Well, it's 11 years now, and I'll talk later about how things have progressed. But fortunately, Maureen Gardner found me. I found her at a conference and told her what happened, and she directed me to Dr. Andrew Duker, who's been my hero. He's been my doctor for the last 11 years, and things have gone quite well since then. But at first, my fears were that I wasn't going to my boys wouldn't want to see me in public. I'd be an embarrassment to them. I was fearful of being a burden to my wife, and fearful that my life was going to be severely shortened. None of those things have come to pass. So, but that was my introduction.
Thank you, Dan. Rick, can you tell us about your diagnosis and what your fears and expectations were? You need to unmute yourself, please. There we go.
Okay. My story is very much like Dan's. When I first heard that I hadn't had it, I cried. My wife said, "Well, how do you feel?" I said, "I feel like crying." So I did. But I also felt great relief because it wasn't cancer. My father died of bone cancer, had many of the same symptoms I had, and I thought I had cancer. So there was great relief. There was hope because I knew the disease was treatable. And so I thought, mine will be treatable. My greatest fear was, would I see my grandchildren grow up? And my first grandchild was born a month after I was diagnosed. And she's going to graduate from high school this year, and I'm still here. I thought I would live 10 years like Dan. It's been 18 and a half. So I've had it for a long time. I feared that I'd be confined to a wheelchair. I do use a walker, but I didn't want to be in a wheelchair. I still don't want to be. I knew it was progressive disease, but it's progressed slowly for me. I'm very thankful for that. So those are my expectations.
Thank you.
Okay.
Thanks, Rick. Now I'll tell you what my fears and expectations were when I was diagnosed. First of all, I did not expect to get Parkinson's. I expected, unlike Rick, to get cancer. There was a lot of cancer in my family, and my mother and all three of her siblings had cancer. My mother contracted breast cancer at the age of 29 and died when I was 6. Since breast cancer can be strongly genetic, I always expected I would get breast cancer. When I was diagnosed with Parkinson's in 1998, I said, wrong disease. I wasn't prepared for Parkinson's. Naturally, I was surprised, but not completely shocked, because both of my maternal grandparents had had Parkinson's. So my next expectation was that I would be like my grandparents. My grandmother, who lived to be 90, was confined to her bed for the last few years of her life. My grandfather spent the last few years of his life refusing to take his Parkinson's medication and shuffling around the house with little teeny steps. So I thought I knew a lot about Parkinson's, because I knew that theirs had turned out. But it turns out that I was early onset, which Dr. Lynn talked about. I was only 39. And people with young onset Parkinson's tend to progress more slowly and have sometimes more or at least different complications down the road. So when I asked the doctor who diagnosed me what the prognosis was, I expected the worst. But he told me that within each individual, Parkinson's tends to progress at a consistent rate, and that rate is different for every person with Parkinson's. So we would not know until I had been observed for a while what that rate would be for me. So I felt the fear of the unknown and the expectation of a rapid decline. Another expectation was that I would not be able to be a good mother to my children. I had 3 children. They were 14, 12, and 9. At that point, I was a single mom and did not know how quickly my abilities would decline. But my children were, at least initially, more of a help than a burden because of their attitude. Their reaction to my diagnosis gave me hope. My 9-year-old assured me that things would be okay. When I said that I would miss things like taking my grandchildren to the zoo, she said, we can push your wheelchair at the zoo, and since you can get a handicap parking permit, we'll even get the best parking place. Now that 9-year-old is 35 and has 2 daughters of her own, and I have indeed been to the zoo several times with all 5 of my grandchildren. So I felt inspired to focus on how I was doing each day, and more not to look too far into the future, because I realized I might be worrying about things that would never happen or that I could deal with when I get there. So the next question that we're going to answer is, how has the progression of your Parkinson's compared to what your fears and expectations were? Dan.
My doctor has told me that according to his charts, the Parkinson's has not progressed at all since I've been seeing him. But he said, I know you know differently, and I do know differently. I can still pass all the tests and do the things he shows me, but my voice, I feel like I'm screaming right now, and my voice gives out quicker than it used to. And I've been in ministry, so my speaking is not as good as it used to be. Someone was talking about texting. Typing is really hard. Like, you know, all those extra A's you get when you're thinking. You're looking up and you look down, there's 25 A's across the screen. And in texting, you try to fix the word, you try to find the spot, and I spend more time trying to fix my text than I do in a conversation. My handwriting has gotten to where I can't decipher it. And so taking notes with a pencil is not possible. Stiffness, waking up at night, not being able to go back to sleep after 2 hours, not being able to go to sleep, getting what I call the jitters. All those things have happened, but I can honestly say that there's still people in my life that don't even know that I have it. So I never thought that was going to be possible after 11 years. So it's affected me more physically than the doctors might write on their charts. But I think part of me, I lived in Ethiopia for a number of years, and I saw a lot of really good people die very young just because they didn't have good medicine, good opportunities. So I don't ever say, why me? Because I say, why do I have such an advantage of such great medical people and such great places to exercise and great places to meet people who like this, people who are going through it and being able to get some community and some encouragement. So it has not progressed at all like I thought it was going to. It's 11 years. I'm still alive and kicking, and I'm still running. Not as much as I used to, not as far as I used to, but life is good.
Thank you, Dan. Rick?
It's been a roller coaster ride. Seems like something good would happen. I get up, and then all of a sudden I take a plunge. I had several setbacks at the beginning. I had low blood pressure. I had to quit teaching because I passed out. Couldn't do that in front of a group of third graders. I had dystonia in my foot. And I, like Dan, was a runner. I couldn't run until I got a device called a walk aid, which stimulated my foot. I was able to run again. So that was a high. I had 6 surgeries in 3 years.
Oof.
So, and they were major surgeries. But my fears and expectations were not realized. My grandkids, I play with them and can talk to them and see them. And my oldest granddaughter, as I said, is a senior in high school, and I cherish the moments. I've lived 18 and a half years with Parkinson's, and overall they've been good years. Like I said, it's been a roller coaster ride. One of the biggest things was phenomenal fatigue. I just seemed like all I did was rest. And Dr. Espay says that it miraculously went away. And I agree with that. So it's been up and down, but it's been good. God is good.
Great, thank you, Rick. For me, the symptoms themselves I have found to be manageable in a way I did not expect. The progression of my Parkinson's has been quite slow, and I've been able to adapt along the way. The symptoms that bother me the most are difficulty with walking, posture, sit up straight, balance, and coordination. And I also have orthostatic hypotension. I was so glad to hear Dr. Lynn use that term, because makes me sound so smart knowing what orthostatic hypotension is. It's just a great phrase. But it's Rick mentioned it as well. It's when your blood pressure starts very low and drops when you stand up. If I even walk upstairs too fast, my blood pressure will I get a head rush from that. So I've adjusted to the increasing severity of each of these symptoms by targeting the symptoms in my exercise and by putting safety rules into place for myself, such as always taking hiking poles when I go hiking. And important rules like that. It's very difficult to be aware of what you're doing all the time, as much as you need to do to really be safe with Parkinson's. And it's exhausting. I will agree with Rick that fatigue has been an issue for me, because I think it's just exhausting to be that on target all the time.
Mm-hmm.
It's not easy to control my tendency to take small steps or my lack of balance, but when I work hard to correct these deficits, I can make a difference. Okay, so now the third question is, what steps have we taken to manage our Parkinson's? Dan?
Well, Maureen Gardner had an impact on the first two, and the first one was getting a great neurologist who has helped me a lot, who listens to me and treats me with great respect and wants to know everything I'm experiencing. The second thing was Maureen told me I should exercise regularly. And I said, I do, I run, I do things. She said, well, there's places that do that, especially for people with Parkinson's. And I thought, well, they're older and they don't do as much, and I don't want to do that. So then she pulled one on me and said, well, some money's been deposited into the account over at Forever Fitness in your name, and if you don't use it, good people's money is going to go to waste. So I started going twice a week, and that was about 8 years ago, and I haven't stopped. The exercise has made all the difference for me. I think exercise is the #1 medicine for Parkinson's. And of course, Elizabeth will talk about that. She's my hero. But I found that exercising with people who are going through similar circumstances is great. You get to talk to them before and after, you get ideas from them, and there's some strength in community. So exercise was big. I had to also listen to my wife a little more. I still don't like to be told I can't do things. So this year is the first year I've not gone up on the roof to do a few things, because I've had to acknowledge that my balance isn't what it used to be. I'm still running. I still do a lot of things. I still think I can get on the roof, but I'm not. So I'm realizing I have to accept some advice from people, even though I don't want to. I went with Caitlin Fattori with Speak Out, was helping me with my voice, and others know more about it than I do. But I went to a class with Caitlin, and that helped my voice a lot. Helped me realize that I'm not screaming, even though I feel like I'm screaming, and helped me to know how I need to enunciate better, and that's helped a lot. So I think for me, I got to continue to exercise even when I'm tired. I have the same time feelings as you guys do, but I have a lot of thankful, a lot of good people in my life that have helped me. Sarah Palmer and her husband Bill and Kaz at Forever Fitness have changed my life. So I really recommend getting involved in a place like that. I know there's a number of options, but and the second thing is stress is the biggest downer for me, and it can make my symptoms worse. So I have to try to work to get myself out of those situations. So exercise with the right people, speak out, working on the things that you have weaknesses in, and trying to live a stress-free life, which of course is impossible.
Thank you, Dan.
Yeah.
Rick, what steps have you taken to manage your Parkinson's?
The biggest thing is I have faith-based hope that I will be healed. Maybe not on this side of eternity, but I will be healed. And that has helped me deal with it a lot. I decided early on I was going to be positive. I wasn't going to sit around and have a pity party. I was going to do things, and my world was not going to change. Well, it has changed, but being positive has made a big difference. As Dan said, the neurologist makes a huge difference. Dr. Espay is my neurologist. He's a movement specialist. I think anybody with Parkinson's ought to go to a movement specialist. They just know so much more. And then not only go to him, but I go regularly and I do what he says. I think that's important. I think another thing that's helped me deal with it is I take my medicine on time, all the time. I don't say, well, I'm feeling good today, I don't need it. I think that's very important. I've done things Dan said, speech therapy with Caitlin. I'm physically active, exercise, I'm in a boxing class. I find it necessary to be around people who have Parkinson's disease like I do. I think a big thing is I've invested in others. And I think that helps me deal with what God gives me. So those are things I would say. And I agree, exercise is so important. And that includes my voice, my body, my arms and legs, and includes it all. So those are things that I've done.
Excellent. Thank you, Rick. So what steps have I taken to manage my PD? The first and most important is exercise. Is this, we have an echo in here somewhere?
Yes.
When I was first diagnosed, I had a friend who set up walking buddies for me, and I tried to exercise maybe 2 or 3 hours a week, which I thought was pretty good at the time. Over the years, I've added more and more exercise opportunities as I've realized how important exercise has been in slowing the progression of my disease. I attend Parkinson's specific exercise classes 3 or 4 times a week. I walk or hike. I do Tai Chi and yoga. I work out with 2 different personal trainers who specialize in Parkinson's. And I do Parkinson's boxing as well. And in February, I shovel snow. Currently, I exercise at least 12 hours a week. And it's just made such a difference in my life. When I'm retired, I was able to have more time to exercise too. I truly believe that the reason I can manage my PD is I have slowed the progression by exercising a lot. And when the rate of decline is slow, I can adapt along the way, and I get used to each new symptom by taking them on one day at a time, and I can deal with it. I've also tried to learn as much as I can about PD. I've attended conferences, webinars, and meetings. I've read books and articles. I've worked to make information available for others with PD as well. I've even written a book about hiking and Parkinson's. As I learn more, I've also learned that many families affected by Parkinson's need more information and support than they are getting. This has led me to become involved in the Parkinson's community. My involvement in the local PD community has taken many forms. As Chris mentioned, I'm on the board of Parkinson's and Wellness. I've been on the board for more than a dozen years. And I've been instrumental in starting exercise classes, the Dance for PD program, and the Steady Stride Singers. I find this community involvement very rewarding because it keeps my brain active and at the same time sends me an abundance of gratitude from others. It also helps me stay connected with other people. And social connection is very important for people with Parkinson's. A recent study actually found that the single best predictor of decline in Parkinson's is a sense of loneliness. Mm-hmm. Finally, although it's easier said than done, I think perhaps the most beneficial step I've taken is my intention to keep a good attitude, which I think the other 2 also would echo. Attitude makes a huge difference in the amount of stress in my life. And just believing that I'm doing something proactive gives me hope that I can continue to stand up to this disease and I won't let it completely control my life. So that's our perspective. And if anybody has any questions, I would love to entertain them.
So I'll remind everyone that you can place your questions in the chat box, and we do have a couple that have come through. So and 1 or 2 that are comments as opposed to questions, but I'll go ahead and moderate those. Mary Jo said to everyone, I can type fine, but texting and handwriting are challenging. So I'm working on family genealogy while I can, trying to remember to use the stylus, adapting to changes. Mary Jo and everyone, I will do a little tease. Later in the year, one of our webinars, one of our PD EDUs is going to be about technology and how to use and adaptive technologies. One of the things I always go to my grandchildren when I want to learn about technology, even though I spent 40 years in technology sales, they still know better than I. When I'm having trouble with texting with my thumbs, my 14-year-old granddaughter just says, Papa, there's a microphone button. You can just hit that and speak. and it'll turn your speech into text.
See, I just learned that from you. I mean, I'm learning there.
Well,
I always said there's more things I don't know, but I don't know what it is that I don't know. But
well,
one thing, the library will work with you. They even do Zoom things. I found out that my Fitbit, I can set it for my medications 5 times a day. And as long as the battery's charged, it works great. I didn't think about that, but you know, that type of thing.
so we'll be doing a program on that in the fall.
Good.
So again, I'll refer you to our website, parkinsoncincinnati.org. And under the Learning tab, you can take a look at the PD EDUs. You can register for them, and we'll have a list of future ones coming up pretty soon. The program committee has solidified our schedule for the remainder of the year. Cynthia Heinrich wants to know, can you say more about Forever Fitness? Dan, you mentioned Forever Fitness.
Yeah, I know there's other groups out there, but they've been great for me. Sarah and Bill head that up, and what they do is there are exercises. There's boxing, there's a circuit, there's a bounce, there's Elizabeth knows all the different classes, but they do things to combine both your thinking and your body, your physical movement. So they'll adjust it to your level. If you're not as mobile as you think you have to be, you'll be surprised. They'll have exercises for you. If you're very energetic and you've got lots of ability, they'll work you out too. So they'll work based on your level. It's in Blue Ash. I live in Finneytown, so I drive half an hour to go there each time, but it's worth it to me. Elizabeth, you can add to that.
Yeah, Sarah is one of the most highly qualified PD exercise instructors anywhere. She one of the only three. Well, the National Parkinson Foundation has a system that of exercising, and Dr. Lynn's slide had that on that their system on there. They have a certification process that Sarah helped develop, and one of the only 3 of the certified programs is the Power program, and Sarah is one of the few instructors here that follows that program, and she's also a national instructor for that program. So she's highly qualified, and she does a lot of very interesting, fun things in her classes. And I highly recommend Sarah Palmer for Forever Fitness. And I see someone says the NeuroFit Gym is also a great place. The NeuroFit Gym is also, it's true. That's over on the west side of town. I think it's like in Hamilton or something. But that's a great place too. Oh, someone asked about books. Parkinson's Disease for Dummies is a really great book. I mean, it's a silly name and a franchise sort of publishing company, but it's an excellent first book for Parkinson's. Also, the Davis Finney Foundation will send you a book called Every Victory Counts, which is a manual for being proactive about your Parkinson's. It's a wonderful book, and it's free. So the Davis Finney Foundation. You can order it on their website. Let's see.
Okay, I'm going to jump in on that one too.
Okay.
If you are interested, you can contact us. Our email is info@parkinsoncincinnati.org, and we can hook you up with a couple of authors that have been speaking here this morning. Elizabeth and Rick have both authored books, and we'll be happy to hook you up with them so that you can get copies of their books. They're excellent. Any other questions at this point? surprised nobody asked you why you guys that participate in boxing for Parkinson's don't have bruised faces. But
The non-contact boxing. You don't hit people.
It's a great workout though.
It
And
is.
it is indeed.
And one thing I'll say is I didn't mind if people found out I had Parkinson's. I didn't broadcast it, but I didn't mind if they found out, but I didn't want to be known as the guy that had Parkinson's. And I didn't want that to be my identity. And that really bothered me for a while, but now I just realize I'm a blessed person who happens to have Parkinson's, and however they want to identify it, so fine with me. My identity doesn't come from there. It comes from me being a child of God, and He's got a plan, even though I don't understand it, and I'll work within it. So I don't worry about the labels anymore. Rick, looks like you're talking, but I can't hear you.
I think about how many people I've known since I had Parkinson's who I would not have known. And it's a large number. So I think God's put them in my life. So
We have a great Parkinson's community. Our organization, Parkinson's Support and Wellness, is a rather small one. We have only 3 paid staff, and each of them are part-time only. What we're able to accomplish with our education programs, with raising money to fund the various exercise programs and therapies specific to Parkinson's in our area, is largely due to a cohort of volunteers. And each of the persons that have been speaking on the panel today have been very helpful to us in volunteering and participating in various events. And we're deeply grateful to the fact that this is an organic group, organization that is grassroots if there ever was one. I'll personally thank all 3 of our speakers today, Dan, Rick, and Elizabeth. You are my heroes. And I will take this moment to do one commercial, and that is to remind you that if you think today was good, wait until Saturday, April the 20th. At the Manor House in Mason, Ohio. We've been doing the Spring Forum for many years. We hope to continue to do them. During the pandemic, we had to do them virtually, but now we are able to gather as a community again at the Manor House. That's a Saturday morning. Doors will open about 8:15. Program gets started at 9 a.m. We have continental breakfast. We have a wonderful lunch. It's a wonderful location. Great presentations. I think you'll particularly enjoy the play, What I Didn't Say, a journey through Parkinson's, and an opportunity to meet with exhibitors of companies and organizations in our service area that serve the Parkinson's community. You can sign up right here on our website. So with that, I will thank our speaker today, Dr. Iris Lynn. I'll thank our panel, Elizabeth, Dan, and Rick. Maureen, who heads up our program committee and helps to make sure that we have these programs every month. And finally, I'll thank everyone who joined us today and look forward to seeing you next month when we have our PD EDU.
Chris, can we say one word about Beyond the Basics?
Absolutely, please do.
I have a program that will take you from the basics a little bit farther. What's your next step for your Parkinson's journey? And it'll be, we haven't arranged the date yet, but it'll be 1 or 2 Saturdays in the next couple months. So we'll make sure we email everybody who was at this program to inform you about what's going on. Thank you.
Thanks, Elizabeth, and thank everyone for giving us 2 hours on what started out as a gloomy Saturday, but now the sunshine, at least outside my window, is starting to pour in. So have a great Saturday, have a great weekend. And I did get a text a few minutes ago. So in the unlikely event that there are any other rugby fans, my son texted to say the France-Scotland match has been fantastic. So I'm gonna go find the recording and see just what has made it a fantastic match. Thanks, everyone. Have a great weekend.